Today, topic is gestational trophoblastic disease. Have you ever heard for this disease? What do you know about this? What does trophoblastic disease mean?
This caused by
Trophoblasm. Trophoblasm is related to placenta, right? Imagine an embryo. It goes to the endometrium and implants there. After blastocyst stage, there are two different pieces of the embryo. One is trophoblastic tissue, another is inner cell mass. Inner cell mass makes the baby, and trophoblastic tissue makes the placenta. Today's topic is gestational trophoblastic disease. What does it mean? Let's look. The definition is the cellular proliferation of trophoblastic tissue. Where does it come? Originating from Wilder's trophoblastic tissue. Next, please. Next slide, please. Why did I put this picture here? You see European countries on the right side, and on the left side, Turkey now. More or less 10 million births per year in Europe. In Turkey, do you know how many baby born in Turkey? In 2023.
1.1 per month.
No. Less than 1 million. Less than 1 million. 900,000, 23 or more or less like this. Less than 1 million. But 5 years ago, it was about 1.2 million. It decreased very much. So, what is the incidence of molar pregnancy? When you look at this, as you see, the incidence is 1 in 1,000 delivery. In Turkey, let's say 1 million baby comes. That means 1,000 molar pregnancy will happen in a year. But what is the incidence of choriocarcinoma? The incidence is between 2 to 7, but 100,000 pregnancy. If we make a yeah, 50 gestational trophoblastic neoplasia, that means choriocarcinoma or invasive mole or placental site trophoblastic tumor. But usually, when I say gestational trophoblastic neoplasia, you will understand choriocarcinoma. How many? Just 50 patients. So it is very uncommon problem in our country. But molar pregnancy, that's okay. 1,000 molar pregnancy in a year. There are more than 81 cities in Turkey. Let's say 10 to 20 molar pregnancy happens in a city. But of course, it is related to the population. More of them will happen in Istanbul or Ankara. Even in Ankara, it is very uncommon problem for gestational trophoblastic neoplasia. Let's go next slide, please. There are two different diseases. One is gestational trophoblastic disease. That means there is no malignancy for these patients for this disease. But the second one is gestational trophoblastic neoplasia. When we are talking about gestational trophoblastic disease, we are talking about the highly form modes. These are not malignancy, but they carry permalign potential. They can turn into the malignancy. They can go through invasive mode, or choriocarcinoma, or placental cytoplastic tumor, or epithelioid trophoblastic tumor. Next slide, please. In that slide, as you see, there are two different forms of high-death-form mode. One is complete mode, the other one is partial mode. What does it mean? I'm going to explain what is the complete mode and partial mode. This slide shows us the potential percentage of the modes to go to the choriocarcinoma or invasive mode. We call it gestational trophoblastic neoplasia. As you see, 15% of complete mode can turn to choriocarcinoma or invasive mode or placental cytoplastic tumor or epithelioid trophoblastic tumor. But when we are talking about the malignant form, please keep in your mind, complete mode can turn to choriocarcinoma. Complete mode, choriocarcinoma. Of course, they can go to invasive mode, but the problem is choriocarcinoma. Even if the complete mode turns into the invasive mode, it is very easy to treat it. But the problem is choriocarcinoma. Sometimes it is easy to treat it, but sometimes it is very difficult. But sometimes it is not possible to treat it. That means the lady will die of this. And the incidence of partial mode turn into choriocarcinoma, it is very uncommon. Just 1 or 2% of that will turn into choriocarcinoma, will turn to the cancer. That's it. But the most important problem is if a choriocarcinoma comes from normal pregnancy, imagine a lady give a baby grows up, maybe 1 year old. After that, we diagnose choriocarcinoma for this baby. That means that choriocarcinoma happened after normal pregnancy. If a choriocarcinoma happened after normal pregnancy, it is very difficult to treat it. That means it has bad prognosis for the future for the patient. Next slide, please. What is the epidemiology for oral pregnancy? Let's say, more or less just 1 in 1,000 pregnancies. It changes country to country, but more or less the same. Usually, they say if the pregnancy happens under 15 years old or happens 20 years old, the incidence is increased. Some studies say maternal age is important. Some studies say paternal age is important. There is a risk factor for trophoblastic disease. And some studies show us if a patient takes low protein diet and deficiency of vitamin A and beta carotene, the incidence increase. But nobody knows why this kind of disease happens. It is unclear. Let's say it is unclear. The another risk is history of molar pregnancy. What was the incidence for a lady, normal incidence? 1 in 1,000 pregnancies, right? If a lady had a 1 molar pregnancy, the chance of second pregnancy for molar pregnancy will increase so much, 10 times increase. Roughly, what can we say if a lady has a complete mole? What is the chance of second pregnancy as a molar pregnancy? 1 in 100, right? If a lady has 2 molar pregnancy in history without having any healthy baby, the chance will increase 1 in 10 or more. If a lady has more than 3 molar pregnancy, there is no chance for healthy baby. It is called as recurrent molar pregnancy. If you see a lady, if she says, I have a molar pregnancy more than history more than 3 times, you have to think about there is no chance for this lady to get a healthy baby. Yeah? Is it clear? Please wait and ask me a question after. Okay? Let's go. How is the cytogenetics? Usually, complete mole is higher incidence than partial mole. 70% of them is the complete mole and 30% is for partial mole. Let's go. Let's go again. Go. Go, please. Okay. What is the chromosomal structure for complete mole? Complete mole, because of empty oocyte. What does empty oocyte mean? There is no nucleus. There is no chromosomal structure within the oocyte. It is called as empty oocyte or empty ovum. If just one sperm fertilizes the oocyte, after it starts to divide for an embryo, it is duplicated, for example, for 46XX chromosome. It is not possible Y chromosome because there is no 46YY chromosome molar pregnancy. So that means empty ovum must be fertilized by X chromosome, X paternal chromosome, in order to duplicate. It is called as dialectic androgenesis. Second slide, please. Another option for complete mole, there is an empty oocyte, but 2 different sperms fertilize that oocyte. The total number of chromosomes also same, 46XX or 40XXY. It is possible. But 46YY, it is not possible. So it is another option for complete mole, 46 chromosomal structure. It is called as spermic diploidy. So if you ask a question, how many chromosomes carries on a complete mole, the answer is 46 chromosomes for complete mole. Go please. For partial mole, there is a normal oocyte, 23 chromosomal karyotype. If two sperm fertilize the oocyte, the number of chromosomes for partial mole will happen 69 chromosomes. 69 XXY, 69 XXX, but not possible, 69 XYY or 69 YYY. So there is a triploidy structure. This spermic triploid. This spermic one oocyte. Go please. What do we see on screen? You see hydrophobic vesicles, right? As you see here. Here. And if you take up some piece of, and if you look at under the microscope, you will see like this. It's a hydrophobic villi. This one. You see, elevators, large villi mixed with fibrotic small villi, multifocal trophoblastic proliferation. This is a big hydrophobic villi, this is a trophoblastic proliferation. Go this. Next slide, please. Yeah. Can you go before one? No, back. Go back. Yeah. What are the differences between complete mole or partial mole? This is clear, right? Go next one. Yeah. Actually, both are same slide. Let me explain on that side. Hydate mole complete. How many chromosomes does it have? 46, right? Usually XX, but sometimes XY. There is no fetus, absent fetus, incomplete mole. Diffuse sorting of villi. When you look at the villi, you will see all of the villi carries a hydrophobic appearance. But in partial mole, fetus can happen. Focal stability or villi, focal trophoblastic hyperplasia, and chromosome number is 69. What happens in the invasive mole? I'm going to explain what is the invasive mole. There is a myometrial invasion, swollen villi, hyperplastic trophoblast. If I ask you a question, what is the difference between the invasive mole and complete hydate mole? Please check the screen, read the screen. What is the difference between the invasive mole and complete mole? Is there any differences? Except myometrial invasion, is there any differences more? Let's speak up, please.
It is not a benign disease like the other moles, it's a malign disease.
Which one is the malign?
Invasive mole is
No, we cannot say it's a malign form. Is that you see It says myometric imaging, small villi, that means hydropic villi, right? I showed it before. And it says hyperplastic tropoplastic. It doesn't say any anaplasia or atypia. Imaging doesn't mean cancer or doesn't mean malignancy. Like endometriosis. What does endometriosis mean? Endometriosis means if an endometrial tissue goes everywhere, usually endometrial tissue goes to ovary or fallopian tube or the peritoneal cavity. It is endometriosis. It can invade periton, it can go to rectum or bladder, but invades the wall of the bladder. But it is not cancer, right? Invasion doesn't mean malignancy or cancer. There is no difference, right? Just myometrial invasion. All other structures are same. And when we look at the choriocarcinoma, what is the difference between invasive mole and choriocarcinoma? There is abnormal trophoblastic hyperplasia, right? It says it is a cancer. And anaplasia. What does anaplasia mean? Anaplasia means that there are some atypical cells. That means that these are the cancer cells, right? And absent of that, there is normal. And there is hemorrhagia and necrosis. If a tissue has a necrosis, that means there is a very aggressive cancer there. So, as you see, we can say choriocarcinoma is absolutely cancer, invasive node is not. Just invasion. I will not explain what is the placental cytoplastic tumor because it is very uncommon. If you want to read or to know something, you can read it. Yeah, go please. What are the symptoms? Irregular bleeding, exclusion of molar vesicles. Usually ladies say, I have something coming from my vagina. It looks like a grape. The lady tries to explain some small vesicles. But currently, actually, it is not so common. Because our health system is very well, usually patients go to the doctor and the hospital. Usually, they are diagnosed very early. If the disease goes up after 16 weeks of the pregnancy, usually they come with these symptoms. Now, vomiting, preeclampsia-like symptoms. Do you know what is the preeclampsia? Yeah, it is a kind of gestational problems. Usually they have hypertension, edema, and proteinuria. And usually it happens after 24 weeks older, the baby. But if a patient has a preeclampsia-like symptoms in first trimester, before 20 weeks of pregnancy, yeah, you should take into consideration maybe it is partial mole or not. You will check. Because what was the difference complete mole or partial mole? When you look at the using ultrasonography, you will see baby. If you will see baby and the lady has a preeclampsia-like symptoms, you should take into consideration. It can be fashionable. Next slide, please. Tachycardia, hypertension. Yeah, if you have a question, you can ask. Go. Acute respiratory distress syndrome. Because some piece of thrombus, some piece of the tissue, more tissue, can go to the respiratory system, to the lung. So the incidence is very rare. But tachycardia is more common. You see, these are the tachycardia cysts. These are the tachycardia cysts. Actually, all of them are the follicle. For example, ultrasound. You see this picture. If you start the treatment for a woman for IVF, for in vitro fertilization, if you give the gonadotropin, you see the ovary like this. But what is the difference between MUM and IVF patients? Same. In that picture, ACG stimulate the oocyte. For IVF patient, human menopausal gonadotropin or follicle-stimulating hormone stimulate the oocyte to grow up. Yeah. Okay. If we make a brief conclusion, let's remember what I said. In partial mode, usually in complete mode, the lady has a large uterus, lady have a tachycardia cyst, hyperthyroidism, nausea and vomiting. It is possible to have a preeclampsia and very high ACG level. Why? Because there are trophoblastic proliferation. Go please. Diagnosis. Usually diagnosis, if you listen to the patient, if you listen to the patient's symptoms, irregular breathing, large uterus, tachycardia, hypertension, signs of hyperthyroidism, and usually we make a diagnosis by ultrasound. There is a specific picture. Let's go. This is a vesicle. You see, this is a complete, because you don't see any focal structure. The difference is between the complete mode and partial mode. You see somewhere the big hydrophic review, not diffuse, and some normal tissue. In this picture, you see there are hydrophic villi or aura. Let's go. This is the picture for complete mode. You see? This is specific. All the doctors, even if they are junior, when they see this picture, they say, the lady has a complete mode. Let's go. This is the partial mode. You see, more or less the baby has a normal appearance, but when you look at the placenta, you see hydrophic placenta and large placenta. The lady has a large placenta. It is bigger than the baby. But chromosomal structure is the 69, right? It is not possible to lie. Yeah, let's go. You see, trophoblastic proliferation surrounding the oedematous villi, and this is a central cisterna form. That means two or more oedematous villi comes together and make a big form of villus, right? Empty villus. Go. Yeah, this is the invasive mode. Here is the wall of the uterus. Here is the empty cavity of uterus, endometrial cavity. The disease starts there, and then invades the myometrium. This is the invasive wall. How can we diagnose this? It is not possible. Without taking the uterus out. For diagnosis, you should remove the uterus and cut some pieces, and you need the microscope. If there's any trophoblastic tissue within the myometrium or not. If you saw trophoblastic tissue within the myometrium, we say this is the myometrial invasion. So you have to say this is the invasive. If you don't remove the uterus, but usually it is not possible, because the first choice for this patient is not to remove the uterus, is not hysterectomy, because all of them are young. They are at the age of reproductive period. They need more pregnancy, more baby. So, how can make a diagnosis? I'm asking you, imagine a lady, you made a diagnosis for complete mode. What will you do for this patient? Will you prescribe some medicine? Will you take the uterus out? Remove the uterus out? Or will you give some medicine or, sorry?
We should do a vacuum cryptation.
We have to allocate the multilateral forms from the uterus side. It is called as dilation and evacuation using suction curettage. What does suction mean? Suction means introduce MM. Like vacuum cleaner. Yeah, it is called as like vacuum cleaner, right? Suction cleaner. Why you have to use suction cleaner, suction curettage? Because there are many trophoblastic tissue. You have not to the press trophoblastic tissue to the myometrium. In order to prevent trophoblastic tissue go everywhere, go to, for example, myometrial wall or lung or other organs of the body. If you use suction curettage using vacuum, it is very easy and safe. You evacuated this patient. What will happen later? At this time, the treatment finished. You have to check what will happen in future. What is the risk of this patient? 15% of them will turn into neoplasia, right? I said this. After evacuation, after dilation and suction curettage, treatment finishes. But we have to check what will happen in future. How can we check the patient? You should take blood in order to understand HCG level. If the concentration of the HCG goes down, there is no problem. It must decline under 10 milli-international unit per milliliter. If HCG level doesn't decline anymore, if HCG level increase week by week, if HCG level decreased sometimes, but persist again, even if the period passed 6 months, so we say HCG level drops a plateau, increasing HCG level, persistent HCG. Go please. You evacuated the patient and she came back and you understood that HCG level at 2 or 4,000 milli-international unit per milliliter. What will you say? You will say this is a persistent hydroxyl mode or invasive mode because there is some tissue within the body. They produce HCG, right? But it is the one option, invasive mode. The another option, hydatidiform mode turned into choriocarcinoma. Is it possible? What is the risk of hydatidiform to turn to choriocarcinoma? Sorry? 15% of hydatidiform mode turns into invasive mode or choriocarcinoma, right? The first one is not malignancy, the second one is malignancy. But both of them needs to treat. Go please. What should we do after that?